Thank you for the kind invitation. I am going to present preliminary results of a neurointerventional procedure for the treatment of GA and some considerations about Rationale. The year 2024 finds us with two therapeutic options to address GA. Both slow down the progression of atrophy but cannot stop progressive visual loss. The rationale of these treatments is based on the consensus of a genetic predisposition that triggers complement cascade leading to atrophy. But genetics cannot explain why there is asymmetry in the same patient, why identical twins are not equally affected, what the role of smoking, diet, and exercise is. So there is room to propose another theory, that of perfusion deficit. The eye has a complex perfusion system as the retina and the macula in particular has very high levels of oxygen consumption that must be supplied. This theory has a simple and compelling logic. Oxygen availability plays a fundamental role in AMD pathophysiology. Insufficient perfusion reduces oxygen, so impaired perfusion plays a role in AMD. Friedman in 1997 proposed a role for perfusion in AMD. Even if he couldn't be precise about the mechanisms, he always pointed out strongly about a role for perfusion, something that Henry already did in 1974. In his view, perfusion was an understudied aspect, but one that had to have implications in macular ischemic pathologies. Recently, Rosenfeld and colleagues highlight a preponderant role for hemodynamic changes in macular perfusion interacting with genetic determinants. Those theories remain just that, theories, as long as it was not possible to demonstrate that there was a perfusion deficit and that eventually restoring normal macular perfusion could demonstrate any benefit. Considering this background, Okudine was born. Analyzing cadavers of patients with GA, 100% correlation of vascular light occlusion of ophthalmic artery was found. This led to studies in GA patients with controls versus controls using high-resolution MRI, which again found a high correlation of ophthalmic artery occlusion in GA eyes. At the next level, a compassionate study with angioplasty was initiated in Argentina in 5 patients with GA but with a very advanced degree of atrophy. There were no conclusive changes in the vision of these patients, but they were not expected due to the advanced degree of atrophy. This study allowed us to verify that the procedure was feasible and safe enough to initiate a broader study. The new study, whose results we are presenting, includes patients with VA of 2080 or worse. Angioplasty is performed in the worst eye after confirmation of ophthalmic artery stenosis by imaging. The study is carried out in Argentina due to a combination of factors: a world leader in this type of neurointervention, a world-class eye research center, a population with European heritage and prevalence rate of GA, and an efficient and reliable regulatory authority. Patients are evaluated with high-definition imaging systems with specific software to assess the ophthalmic artery. In the image, we can see how focal stenosis of the ostium is identified in 58% of the patients, or diffuse stenosis found in 67%. Another way to assess occlusion is with specialized software that shows flow patterns. In this image, we see how turbulent flow changes after angioplasty to laminar flow. More intense red shows more flux. We explore different imaging and modalities in an attempt to better capture flow versus dimensional-only measurements. The procedure consists of catheterization with a specially designed catheter for the ophthalmic artery with an inflatable balloon at its end. During the procedure, it is already possible to glimpse changes in perfusion. In the left image, during the contrast injection prior to angioplasty, it is very difficult to discern where the eyeball is. In the image on the right, uh, taken 10 minutes after angioplasty, the contrast shows a very clear choroidal blush, reflecting a new perfusion status. The results we are going to show are preliminary but interesting and suggestive. So far, 9 patients have undergone angioplasty and completed 4 weeks of follow-up. 4 of them have a 3-month follow-up, and only 3 have surpassed 6-month follow-up. However, the results are encouraging. Choroidal thickness increased 12.7% at 1 week and remained increased more than 10% at week 4 in the study eye. The fellow eye remained stable, but visual acuity of treated eyes responds unexpectedly. We detected 8-letter gain at week 4, which is sustained at 3 months. Fellow eyes again show no relevant changes. An overlay of occurrent outcomes and natural history of GA progression shows the magnitude of these disruptive preliminary results. It can be assumed that this visual recovery responds to functional recovery due to reperfusion of the area adjacent to the atrophy, which by analogy with neurological nomenclature we can call macular penumbra. The preliminary results of this study are unexpected and promising, but above all, there are a vindication and attribute to the authors who were not so heard before and who thought about the possibility of this hypothesis. In conclusion, choroidal flux deficit has a role in macular diseases. Angioplasty can restore perfusion. Angioplasty is a safe procedure but technically challenging. Angioplasty increases choroidal thickness and improves vision in the short term. Long-term assessment is needed. I want to thank all the team who are working with us in this promising study, and we soon will release more data. Thank you very much.